Thank you all for being here for this hybrid panel on should psychedelic therapists have first-hand experience on substance state administer. So my name is Anna Martins. For those who don't know me, I'm the conference manager of a CPR and the operation manager of ADEPT, which is the Advanced Education Psychedelic Therapies, which is the new project by the Open Foundation. And for those who don't know and not familiar with the Open Foundation, it has been the leading nonprofit on advancing psychedelic research and therapies in Europe since 2007. Before we start, I ask you to keep your phones in silence. We will have a panel followed by a Q&A, so there'll be plenty of time to ask questions. For those who are joining us on the chat, there will be a form on the chat, so you can submit your questions, and we will address as many as we can during the Q&A. So we're doing this panel today because in the context of developing ADEPT, this topic of self-experience was one of the questions that kept coming back to us and is often a topic of debate on the psychedelic field, which is why we invited people who have thought about this question deeply and have a lot of experience in this field to discuss if and why therapists should have self-experience with psychedelics. So I would like to pass the ball to our panelists for a quick introduction, so we can start with you.
My name is Jolien Verraert. I'm a psychiatrist in The Hague, working on a depression clinic, and I'm a researcher at the UMC Groningen, working on a study on ketamine as an antidepressant. And I've been working with ketamine for treatment-resistant depression for the past 6 years now. And I'm very delighted to be here to join the panel on this interesting topic. So thank you for the invitation.
Thank you for coming and sharing this time with us.
Yeah. My name is Mette Somers. I'm a psychiatrist at the UMC Utrecht in Utrecht, and I'm also the medical director of our mood and psychosis unit, which is a ward and an outpatient clinic for people suffering from difficult to treat depression, bipolar disorder, psychosis, or the combination of these issues. And that is also the route how I came into psychedelics research. I've been a local principal investigator for the Compass Pathways Phase 2b trial on psilocybin treatment for treatment-resistant depression. And I also have that role for the upcoming Phase 3 trial on the same subject. And in Utrecht, we also treat people with esketamine nasal spray since a while. So that's also a treatment in this field that I'm involved in. And for me, same as for Jolien, I'm really happy to be here and to share my thoughts on this interesting subject. Thank you for the invitation.
Thank you.
Yeah. My name is Dan Keiman. I'm the educational lead of the program, so I collaborate deeply with Anna, and we're building ADEPT right now. I have a background in spiritual care, so I have a slightly different training background. I've been trained as a Buddhist chaplain, as interfaith chaplain, and have worked with hundreds of clients in non-clinical settings, guiding both groups and individuals through psychedelic experiences. And over the last couple of years, primarily focused on the development of training of both non-clinicians and psychedelic therapists, and primarily supporting individuals with the integration of challenging psychedelic experiences. And yeah, like Jolien and Mette, very happy to be here. I think there's something very special about this topic, and I hope we can really find the sort of like the places where there's some friction, but also not losing sight of the sort of complexity and nuance. I think that this topic really deserves that. So look forward to being here.
Yeah, thank you. Happy to be here. I come from Switzerland. I'm a psychologist. I work in psychedelic research since 2016 at the university. I was interested in it before my studies already. So I have a long way exploring these substances and states through different lenses. And I work in Switzerland because we can work in the framework of limited medical use with LSD, psilocybin, and MDMA with patients. So I'm doing this since a few years in different settings, mostly in groups. In terms of research, we also worked in groups and meditation and also more pharmacological stuff. Together with Felix Müller in the team in Basel, we set up a study on the personal experience of therapists, more a qualitative open label study. Yeah, because I think it's a very relevant topic with arguments against pro and cons arguments, and yeah, we don't really have much data. We have reports and opinions, and yeah, I'm very happy to be here and discuss this.
Yeah. Thank you. Yeah, thank you all. I'm very excited too. I think it's a topic that everyone wants to talk about and hear about, and it's not a new topic, right? While in the past, it was very encouraged therapists and psychiatrists to have this self-experience so they could understand better the patients, what was this altered states of minds that the patients would present. Now it's a topic that we have to really consider a lot of different things. You know, back in the day, it was also, psychedelic was also known as psychotomimetic, which was this literally meaning mimicking the minds, like mimicking the psychosis that led to this idea that these substances could help researchers and psychiatrists to understand the subjective experience of the patient. So I'm curious to start with the conversation of what are your thoughts on having this level of relatedness with your patients? How important do you think it is to understand what they're going through? It's broadly, like respond.
Okay, I can start. So I think that's a very interesting idea that through the personal experience with psychedelics, we can deeply relate with the things that patients are going through. I think we can maybe have a glimpse or a rough idea, but we will never, I mean, saying I know what you experience is never like what I would say. So no matter if it's about the psychedelic experience or whatsoever, I think the more experience broadly in life in general we have, the more perspectives we have, and the more maybe open or empathic we can be with a variety of different experiences. Yeah, if the psychedelic experience as such exists, that helps us to understand whatever a patient is going through. Not so sure.
I'm also not so sure about it. I think that it is important that as a mental healthcare professional, you can somehow relate to what your patient is experiencing. But I'm not sure what the added value of other ways of understanding what they feel above being compassionate about how they feel is. And I think that's one of the basic things that you should have when you treat someone. You should at least make an effort to mentally move yourself into someone's position and think about what this person is going through, try to make a connection. But in the end, it is impossible to really feel what someone is feeling, because they are suffering from something that might be really horrible. If you're severely depressed or severely anxious, it is something that in the end you will not understand. You can only be compassionate about it, and maybe at times you can understand a glimpse of what they're feeling, because you may know feelings of sadness or anxiety, but in the end it is always different. So yeah, I think it is important to understand and to be compassionate about it. But I think it is impossible to really totally understand what your patients are going through. And I also don't think that in any therapeutic relationship that is a requirement. If you look at other medical specialties, you also treat people with fractures or other horrible symptoms that you can imagine how bad it must feel. But the patient will not expect you to have the same in order to be able to be helped by you. So yeah, I think it is very important to relate, to be compassionate, but I think that in the end you cannot really feel the exact same thing that your patient will feel, and I don't think that they will expect that from you either.
I think I really agree with your perspective. I do think that experiencing an altered state of consciousness or experiencing the effects of a psychedelic can help a therapist empathize with how vulnerable a patient may feel using psychedelics. On the other hand, we all know the importance of set and setting, and we will never be in the safe set and setting as the patients, and there will be different levels of resilience or traumatic experiences in the past, or different effects of the psychedelic. So it might even make us believe that we know what the patient is going through, while it will never be exactly the same. So there's also the risk of thinking that you know what the patient will be experiencing.
Yeah. Yeah, and maybe in addition to that, because in the things I was just saying, I was not focusing yet on psychedelics, but I think that a major difference is that the patients will try this because they are in a certain condition, which is a condition of not feeling well, of psychic suffering from, or psychiatric suffering. And this will, I think, always be a very different experience from doing this or having this experience because you want to experience it. Would you want to experience it? So that's maybe in line with what you are saying. It will be a very different experience because your setting is so different. Your motivation to do it is very different. I mean, I guess there will be some overlap in point with the fundamental idea will be very different.
I have a comment or a question regarding your comparison with the broken leg, because this is the biomedical perspective where you can say, yeah, if you prescribe medication for a somatic disorder, you don't have to have the experience. While from the psychotherapeutic perspective, no one disagrees that we need personal experience in therapeutic work. So from that lens, I mean, our patients ask about our experience. They want to know, compared to a surgeon that they wouldn't ask, have you ever experienced the surgery? So I don't really agree with this comparison. Yeah, what do you think, or whether?
Well, I think the funny thing is that no one ever questions whether it's important to have experienced psychoanalysis before you can be a therapist. And I believe that psychotherapists also they report the personal experience as being one of the most important parts of the education. But on the other hand, we have never studied whether the patient outcomes are better with therapists with personal experience. We don't know if they produce better outcomes than therapists who don't have the personal experience. So the funny thing is, in psychoanalysis or in meditation, mindfulness-based therapy, we don't even question it, but in psychedelic therapy, we do question it, and we think it's important to study it.
But that argument could move two ways, right? Because if you were to ask me, especially if we look at MBSR, MBCT, I would personally, and this is my bias as a Buddhist practitioner, just simply not trust that someone that never meditates is going to tell me about meditation. And I don't doubt that someone can repeat what they read in a book or what their instructor told them, but I want to know, so what happens for you if you sit still for 30 minutes and try to focus on your breath and it doesn't work? Well, according to the book, okay, but what about you?
But you would want to know what happens to you when you sit still, and but it doesn't predict what will happen to yourself.
No, and maybe that's you're right at that, and I do think it is a scientific question, right? We don't know if it impacts the patients in either a beneficial or an unwholesome way. But I would argue that it's not so much like what happens for you, but much more from the perspective of me as a patient. It's like I become so agitated when I try to focus on my breath. How do I deal with this? I dare saying that, and I've been in groups like this, that you can feel whether someone speaks from an embodied place of, I know that agitation, or, well, just keep going back to your breath. There's a qualitative difference, and I agree. It's an empirical question. Yeah.
The question here would maybe be: is this embodied? I know what that state might feel for me because I've experienced it. Does that come from the psychedelic experience, or does it come of another, like just life and personal experience of So this is maybe the question about the selection bias. So who is interested in these states, and who is curious about these phenomena and these states and accompanying people through these? Is it people that became curious through their experience, or is it people that already come with certain experiences?
Yeah. I was actually still thinking about your previous remark on the on orthopedic surgeon, because I think it will help if, for example, you as a surgeon has had a procedure, the patient asks you, okay, I'm insecure, how will it work? If you would have that fracture and you would have that same procedure performed, it would probably help the patient say, I know what you're going through. I've had the same. It worked for me, I can walk again. Yeah, so I think in that way, but that's a bit different from what I was saying previously. I think it can help to have confidence in the treatment you are going to undergo if the person in front of you knows what he or she is talking about. But thinking about it further, I think that me as a patient, I would actually be most interested to know if the person that's going to do this with me has the skills to take me through this as good as possible, as you would have in surgery or as you would have in psychotherapy. And can I trust this person in front of me? Do I trust the skills of this person? And do I feel that if I am under anesthesia or if I am under the influence of a psychedelic, and that this person will be there for me, will keep me safe, and will be able to guide me through the process. And I think it can help if you can say to a patient, I know what you're going to experience, sort of, because you're going to do this for a mental condition, and I did this in a different condition, but I think it can help to build trust that the person is going to guide you through this in a good way. But I think it needs more than just that. I think the trust that someone requires to feel secure about someone actually taking the responsibility to guide you through this, to perform this treatment is more than potentially sharing the experience.
But why is it that almost 100% of patients want to know it from you? I don't think that this is the case for surgeons, that so many patients ask them. So there seems to be something in that particular type of altered state. I mean, anesthesia is also an altered state of consciousness, but
I don't know what you all encounter, your experience with psychedelics, or do your patients actually ask you?
I do notice patients, they ask about whether I tried ketamine more often than they ask about SSRIs or other type of treatment. But I think maybe they also already assume things about all the other kinds of interventions. And in psychedelic therapy and research, it is also more common that the therapists and the researchers have self-experience. It's way more common than psychiatrists trying their own SSRIs. So
which you could also advocate for, I think, in terms of experiencing the side effects. But I think that you're also right, because very little people try SSRIs for recreational, spiritual, or existential reasons. Why they do so outside psychiatry with psychedelics. So I think that also makes the subject a bit different for a potential participant for to undergo this, because they know it is a subject that is very much being talked about in the media, and that also has a sort of excitement around it, because it used to be illegal and there are people against it, and there has been a war on drugs. You know, people put this in the context of something larger than just a treatment that is prescribed.
And yet the idea that personal experience is relevant was already present in the therapeutic community before they were illegal. So this is nothing new. So this is not the...
No, but I think that this may be one of the reasons that patients are more likely to now ask you about this than ask, did you undergo this chemotherapy or surgery yourself? It's an explanation.
I'm curious then, how do you reply to your clients when they ask?
Well, I always think it's quite a difficult question, because I think it can go both ways. So I think as a therapist, when you say, I know what you're going through, or I've experienced the same thing, and it can build trust, and patients can feel like, okay, you know what you're doing. On the other hand, I also read about a study that investigated the perception of participants, and they they used questionnaires in about 1,000 participants, and they asked about the perception of the quality and the integrity of the researcher, and also the objectivity of the research. And it said that especially participants who didn't have their own psychedelic experience, they perceived the quality of the research more negative when the researcher was associated with the psychedelic community or admitted self-use of substances. So I think it can be a positive, it can have a positive effect on the trust and the feeling of the therapeutic alliance, but it can also have a negative impact on the way that patients perceive your integrity or your objectivity. So I always, I'm quite hesitant to talk about any personal experiences, and I think it's good to acknowledge that it's an important question and that I understand why they would be curious about it, but I'm hesitant to answer about any self-experience. And also in the case of ketamine, there's no way to legally try ketamine in the Netherlands. So when you say, oh, I've tried ketamine from someone around the corner, then patients would also view you as being participating in illegal activities.
Don't you think that the assumptions for a psychedelic researcher compared to a therapist are very different, like in terms of what you need to, like as a perception to be objective as a researcher, while as a therapist it's maybe not so necessary to be explicitly objective, but more to be able to be open and compassionate? That's a different question.
Yeah, it's interesting. I was really thinking a bit about it because my role in the psilocybin research, but also in the esketamine treatment, is not that of therapist, but of the PI or the one who supervises the treatment. So I'm not in the room, but I think that's different. But still, I do get the questions, and actually not from all patients. Some of them have asked it, and I share what you are saying. I don't go into it in too much detail. So I normally say, yeah, I do have some experience with it because, yeah, I'm interested in what you are going to experience, but I don't think that it is very interesting what I did experience, because I did it in a very different condition than you are going to do this. So yeah, you are going to try this because you want to participate in a trial to see if this can help you for depression. I tried this because I wanted to understand what you're going to experience. So that is very different. So they know that I have some experience, but yeah, I think that this is the level of detail that's also sufficient for them.
What I'm curious about, because there's a couple of things that I resonate with quite deeply. One of them was like, this question cannot be outside of questions around all the other core competencies that we seek to cultivate and train in. And I think many of those competencies are actually real necessities. And this is less of a necessity, if we want to use that word. And I both hear you speak to, well, the set of the client is different than mine, right? They are looking for mental health treatment. And the setting too, right? They're in a trial, and we're not doing this. But if we would fast forward like 10 or 20 years, my personal hope is that these types of therapies would be legally available. I have yet to come across a really seasoned psychotherapist that says, well, I don't have any mental health problems, so I don't need to go into leertherapy. I don't have to do supervision therapy. I don't have to be in that myself. My clients, though, are really suffering with big mental health problems. Me, not so much. So the set is different, so I don't have to go into therapy. Whereas I think most psychiatrists and psychotherapists would say, well, there's a real purpose for being in that type of therapy, because you need to learn about yourself as a therapist. And I think there's something to be said for the fact that as therapists that are guiding clients through psychedelic-assisted therapy, there's some real stuff to be learned about yourself in that particular context. that I don't think you will be able to learn about in the same way if you're not engaging psychedelics. I don't say that that means that those people are going to be less effective in treating clients, but I would challenge a little bit this notion that the two are completely incomparable, if that makes sense. I'm curious what you.
Yeah, that is a very interesting point. So I've been thinking about it while you were finishing your point. And I think what I've learned most from my own leertherapie, or actually,
I don't know what that is.
It's my learning, so my own psychotherapy that I did for my training,
Yeah.
my training therapy, is to better understand transference and countertransference phenomena. And so I think that what I learned there is to better understand things that are happening between me and someone else in the room who says things which make me feel in a different way, which make me understand a bit more why I feel these things, how these relate to things that has happened in the past. And I still think that that is a very important something that you learn from that therapy, even though we did not investigate it too much. And I think that that's a very important part of learning how you relate to someone that is in your hands, that you're responsible for. But that is very much in behavior. So you do something, you talk, you reflect. But I'm not sure what additional level of understanding is further required to handle that situation, because it is not very likely, I think, that you will engage in a conversation where you dive into yourself that deeply. So I can imagine that through a psychedelic experience you can learn things about yourself and understand yourself better than you did very much before. That adds very much to your skills as a psychotherapist or psychologist or psychiatrist. But I'm not sure how that would show in the relationship, especially well, at least not during the session in the treatment room. Because I'm not sure if that will be subject of the discussion in the treatment relationship.
The non-verbal discussion, yes.
Well,
Yeah.
I think also maybe in the verbal discussion during the preparation and the integration, because we all know that the belief in the validity of the treatment and the efficacy of the treatment, not only from the patient but also the therapist, influences the outcome. So if we strongly believe this is an effective treatment, then the outcomes may be better. So maybe a self-experience will also make you feel like you're more capable of handling difficult situations, or more capable of guiding others through that experience, and that makes you believe you're a better therapist. And then well, maybe that also increases the belief of the patient in the treatment. So in that way it may influence the outcomes, but I have some doubt about whether observing many sessions and watching skilled therapists guide others through these experiences, whether that might be of more relevance than having the self-experience.
I think there are two issues here. So one thing is we're not only talking about personal psychedelic experience in general, but from the therapeutic perspective, we're talking about the therapeutic setting, which would be valuable. And there I agree. I mean, transferences can be intensified with the whole setting. This can be, without the verbal communication, be very much about the interpersonal dynamic. So yes, maybe we should not talk about general psychedelic experience, comparing festival or recreational with a therapy session, because this can be completely different. Even within therapy, of course, it can be completely different, but the setting plays a role. And then the other thing about the felt competence, I think this might be let's say, a danger for therapists that have gone through maybe 2 or 3 experiences, and then they think, now I know. So I feel it could be even, or I mean, I've also talked with other people that see it differently. If someone, it can be more critical if someone has gone through a few experiences rather than having none and being really open. And then if you have a lot of experience, you might end up realizing that you don't know so much, so you become more open again, maybe. So on the one hand, being competent and confident in a way that I stay calm, even if hell is going on, but not with the idea I know, but more with, okay, I can stay calm with not knowing.
I've read about this phenomena. I think it was called psychedelic narcissism. So like the ego inflation after one or a few psychedelic experiences and becoming wildly enthusiastic and starting to like evangelism about psychedelics and hyping the potential. I think there might be a risk in.
I think the risk starts not in the super narcissism, but already in the feeling of I think we're all not immune towards narcissistic tendency as therapists. I mean, we want to be good therapists, otherwise we wouldn't do it, to be aware of it. But yeah, before we become gurus, there's nuances in confidence that we might try to be aware of.
I had not been thinking about this solution, but I think your argument is either none or 15 plus.
But I would like to add a conversation in the context of a training, so kind of shifting a little bit. What is the right amount? Is that a right amount? What would be also your experience with your, considering your training that you received as psychiatrist and psychologist? What is your opinion? Do you think they should have the self-experiences, and do we have a right amount? Maybe just exactly what you said, 2 or 3, they have the ego inflation that can, influence the therapy in a negative way, but well,
I guess it's also individually, it differs per person, right? So some people might be more sensitive to the ego inflation and others might not be. So I'm not sure whether there's a certain limit of experiences that you should have.
considering your experience, Elena, you've been in the training for, I think it's 6 times, right? In the training.
Yeah, I mean,
Do you
I
feel like-
imagine that they not only do the 6 times that are part of the study, will figure out. I agree with you. There's no number, I guess. I think there's an association that proposed at least 5. I think it's a bit arbitrary. I know in psychotherapy training, we have to go through a few hundreds of hours of personal experience in therapy. I think that helps if you have some sort of experience with yourself. Then, I mean, I know colleagues that were present in studies. I would absolutely trust them with facilitating the psychedelic experience without them having any personal experience, and other colleagues with a lot of experience I would never trust. So no numbers.
Yeah. I would also think it's very hard to put a number on that, and then it also takes to the question, and then what substance? If you are going to be mainly an MDMA therapist, should you only have experience with MDMA, or can you only be a good MDMA therapist if you also have experience with other classical serotonergic psychedelics? I think this is the thing that I've been thinking about. How would you look into that?
And what about the legal situation? I mean, I think it's a bit interesting to have the idea that we should ask for psychedelic experiences if they are not legal. I mean, there are also breathwork alternatives, or I mean, in the Netherlands, you're more lucky than we are, where you can travel to South America. So I think it's not like there are so many layers. You have the ethical, the legal, the therapeutic,
Financial.
and the financial, maybe also, and then also if someone has a health issue like cardiovascular or any kind of disease that would make personal experience risky. So
And so there's also like medical conditions that would be contraindications for this kind of self-experience, right? And then you would exclude potential therapists based on their medical record.
potentially.
I think one of the challenges that we currently have beyond the sort of like legal challenges are that we're not completely sure, because let's, for example, hypothesize that we could empirically prove that a therapist with personal experience, and we suddenly magically establish its therapy, right? I think it's a ridiculous notion that I'm offering here, but if we do really have a sense that that is important, then I think the problem that you raise becomes less of an issue for me. Because if you want to become a diving instructor, but you have a cardiovascular issue that never allowed you to dive, so you've never been in the water, you just really like watching the ocean, and you really enjoy that, and you read all the theory books about what it's like to dive, and then a client says, I'm going to dive, can you guide me? And you're like, yeah, I'll be up there, I have a phone, you go in. And I would feel very comfortable telling someone, I'm sorry, you cannot become a diving instructor because you've never dived. And I'm really sorry that that's the case, but I don't think anyone would protest if a surgeon that doesn't have it, or a doctor, like someone that went through primary medical training, misses 4 fingers, and we go like, sorry, you cannot become a surgeon. I think everyone's like, well,
I think it's not entirely right. I know a psychiatrist with bipolar disorder that I think would be very good therapists to guide patients through psychedelic experience, but I would be very careful with offering them self-experience with psychedelics. So I don't fully agree with just saying they're not capable of doing this work.
Yeah,
but that's also not what I would like to say. That's not fair.
Maybe it's also the idea of a guide, sorry. Like the idea of a guide is to, I know the goal, and I bring you there, like in a mountaineering or a diving. Whereas I like more the idea of a midwife, and you can be a midwife without having given birth. And I wonder if this would be the case for a psychedelic therapy. I'm still not decided if I think it's necessary or not, but just to like bring some perspectives in.
That's interesting perspective. And I was still thinking about the comparison with the diver, because the dive you're taking is an activity that I don't know how long a dive takes, but yeah, you have to go down, you go up again, and you do some practice before that. So I see the parallel with preparing for a psychedelic administration and for the integration. But I also think that we do not yet understand how exactly psychedelic therapy looks like and how exactly a psychedelic therapist behaves in the therapy, because there are still different models that are being looked into. I think it ranges from the psycholytic model, which I think you are much more experienced in, which may be more about.
It's another discussion.
Yeah. What I mean is having some psychedelic experiences and then having a more extended therapy afterwards to focus on what had happened and see how that integrates. Versus, for example, the trial that I participated in, which looked into a one-time psychedelic experience, being either at a high, medium, or low dose with preparation and integration. So that's much more limited type of therapy. And I think we at this moment we do not know yet how psychedelic therapy will look like. And if, for example, if at some point it becomes registered as the psycholytic model, so you have an experience and then there is some follow-up of therapy, will it then be required from the therapist to know the full experience if a very large part of the therapy is going to happen afterwards in 12 sessions of psychotherapy? But maybe it will, in the end, be much more like the experience itself is the thing, and the therapy afterwards does not need to be that long. Then maybe the importance of being as capable as possible to guide someone through the experience will be of more importance. But how these things will relate to each other, I think at this moment, we don't know yet. So that will also evolve from how these type of therapies are going to end up in our mental health care system.
And I think also the question is, when we have experienced what it's like to dive in a very calm lake, will it help us know what a patient is going through diving in the very rough sea? encountering all these
Yeah,
challenges.
I'm more on the side that if, I really appreciate this notion of either have very little or no experience, like no experiences, or have a bunch of them. I was in close contact with a therapist that was kind of like starting on this path, if we want to use that spiritual term. And I'm not sure that it was an ego inflation or some sort of hypomanic edge, but it was definitely an enthusiasm, an unreal enthusiasm for 2 years. And internally, I was kind of waiting for the difficult experience. And after 2.5 years, I got a phone call like, I had such a difficult experience. And I'm not sure that I'm going to ever recommend this to anyone anymore. And that was the first time that I was like, oh, thank God. Because I think that this evangelical enthusiasm rooted in initial experiences is not healthy. So I would really would add that it's not about the number of experiences, but also whether or not we're being supported around them. And what we're doing in the ADEPT training is we have a facilitation team that supports the sort of, let's call it, personal development of our students. And then we have supervisors that help them go through, okay, what are the countertransferences that might not be so helpful that now are kind of like rooted in your experiences that you're going to have. And so we're trying to support people on both a personal and on a professional level. And so I think it's a relevant question to ask, if you have these experiences, in what context and what kind, how do you work with them then? Because a therapist that had 1,000 experiences but never has been in supervision or therapy around it, I'm like, okay, yeah, you have a bunch of experience, but I'm not sure how that's being leveraged therapeutically.
It's interesting now because you brought in why would a personal experience be important at all? So, for example, becoming aware how difficult it can be, and like also, I think these experiences where you think, oh, this is what I potentially do to my patients, like to become aware. I think this can be one of the reasons why one could say, yeah, it's important to go through it.
So you're suggesting that in the training there should be a setting to create a very challenging experience.
They come themselves. But I would be curious to find out, why do we think that the personal experience is important? Because I think most of us kind of think, yeah, there's a value in it, even though there are also risks. But if we're talking about potential value, what is it?
Yeah. Yeah, so I but it's a bit of semantics. I think it is important. I think it will help because you better understand. You have a better idea of what is going to happen to the person that you're guiding or supporting, even though you have been personally through it, potentially in a very different set than this person. The thing that I'm in doubt about is the word should a therapist have this experience. I think that, yeah, it will potentially help. It is useful. I think it helps you to relate to what your patient is going through. As various other experience will help. I think one of the things that very much helped me in understanding my patient is that a few years ago I went through a quite severe burnout, which gave me an experience that I've never experienced before in terms of anxiety, luckily not so much depression. And after that, I thought, oh wow, now I finally understand what all these patients have been talking about when they spoke about I feel this or I feel this. Even though I think that in the years before that, I was also, well, but they again, yeah, I got nice feedback from them on how I treated them. And so I'm not sure if they noticed the difference. I think I noticed the difference myself. I'm not sure if they noticed, but that obviously has helped me. So I think that I can now better relate to some of the issues that they bring up. But I don't think that every psychiatrist should have had a burnout to be a better psychiatrist. So that's the thing I'm struggling.
But when you look at the other way around, for example, with ketamine, like the experience you have with ketamine, do you think maybe psychiatrists would benefit from having first self-experience with ketamine? with the treatment? Because now this is a treatment that it can be done there. Now looking kind of the opposite way.
Yeah.
Do you think that could potentially benefit?
Yeah, no, you're.
Well, I think they could potentially benefit, but I think ketamine has been offered by a lot of therapists currently in the Netherlands, and I think they're offering good treatment. So I think patients are benefiting, but I think some might be might feel a better therapist when they have their own experience. But I agree, I don't think they should.
And I think the complexity with esketamine, as it is registered in the Netherlands, is purely pharmacological. And so there are, in my department, we pay a lot of attention to the esketamine-induced experience, and we treat it as a sort of psychedelic treatment, but it is not registered like that. So we're still looking into if that actually adds benefit. In most of the places in the Netherlands, it's being given as a drug, as if you would take a SSRI or a tricyclic antidepressant. And so there's not being paid much attention to what's happened to you psychologically and how this changes you. So that would also make it a bit more illogical to ask that of. Then it would be more like asking the psychiatrist to try an SSRI and another drug, which I still think would be useful to try. Yeah, to experience the side effects and other potential issues that your patient will have.
But I think we agree on the fact that this pharmacological model of treating patients with esketamine, it could be improved, right?
Yeah.
By guiding patients through the experience and by improving the setting and the integration.
Yeah, and again, and for that, I think it may also be useful if the people delivering the treatment understands the experience, because it may help them to ask also better questions about what has happened. And so yeah, I think. I think that could help the most. I think that you better know what you would want to know of someone if you can better relate to that experience. So it may help you better in not even in guiding someone through it, but mainly in reflecting on the experience.
It's interesting that you say that, because I think this would also then be a comparison with the researchers. So of course it's two different things, but as a researcher, with a researcher who has personal experience might know which questions could be interesting to investigate, rather than like just being non-objective because he can. So that's just an excursus. So I think to know what an appropriate question could be, or an interesting question.
To know what you want to know. There is another thing I have been thinking about, which I see as a challenge. That is, if this is really going to work, for example, for MDMA, for post-traumatic stress disorder, or psilocybin for depression, we want to make this available to many patients. And then we want to make sure that we have the volumes to actually deliver the treatment to patients. And we already have a shortage of personnel in mental health care system, at least in the Netherlands. So yeah, I think there's also a bit of a tension between the speed with which you may want to train people to actually deliver this to patients, and, for example, saying, no, you only had 11 experience yet, we still need to wait.
Two more.
Two more. Yeah, and one of them needs to be challenging. So I do see the challenge there in terms of making this actually available.
There, I think this model or the idea of learning by doing, I appreciate that a lot. So we work with groups, so that's really what I like, groups, because there's so much interpersonal learning and triggering, and like really a field to learn interpersonally. But it's, I mean, also cost effective more. And what we do is that we have our students, so we're a couple of therapists, and then someone can join and experience that. So I think this way of learning by doing, I think if you're in that field and you tune in that space, you also learn a lot. And there are so many ways that you can like experiential ways of like training things without the necessity to be on substance. So I think there's a value in experiential work, workshops.
I would add that I think especially all of you are in continuing education. Your primary training took many years, right? First a medical doctor, then to become a psychiatrist. I think you are a psychotherapist, right? Or
I'm
also a
missing a
psychiatrist.
few official points to get the certification, but yes,
Yeah.
I'm working
So,
with
so,
years.
and I would be surprised if I would hear you say, well, you know, we have a big problem, so we're going to drop out 4 years of medical training, and I don't think anyone would say that, and so I'm also curious if we turn it around, like, what is it about this particular modality that seems to give, I don't think it gives you that impression, but that seems to give some people the impression that this is a matter of, you know, do 2 months online and then you're good to go and start treating people in highly vulnerable, highly suggestible states with substances that are deeply unpredictable. Because that's a logic that I cannot follow. And I understand this sort of level of urgency and rollout, but what we've chosen for with ADAPT is to say, no, we're going to take 2 years to really help people go through the motions. And it's only 3 experiences, but there's a lot of experiential work where we work sober and we do role play. And I think I think it's deeply important. So I'm curious how you think about that in relation to what you just said.
Oh, let me think. I wasn't talking about these 2 years.
No.
Now you mentioned this.
Yeah.
So yeah, there is a lot of continuous education when you do our work. But I think we already work all the time with people that are in highly vulnerable states, that are in. I mean, if someone is severely psychotic, I think that this is also how people in the early beginnings became interested in psychedelics. These people are very far away in a very in a very psychedelic state potentially, and we already deal with these people. So the situation of people being very mentally destabilized, suffering from what they're experiencing, that is not something that is very new to psychiatrists. And so it's not that you start from zero. You do have a lot of experience with interacting with vulnerable people that severely suffer from all sorts of emotions and different states of consciousness. So this is a very controlled situation actually. So when I first started to do this work, of course I was a bit frightened that people would immediately have very challenging experiencing. In the end, this was totally not that much the case, because apparently guiding people through this can work very well, even with severely depressed, treatment-resistant patients. But I did not consider it that much more frightening than dealing with someone that is in a state of mania or psychosis. So we are used to dealing with different states of consciousness. So it is something new that you learn on top of that, but not something totally new, I would say.
I appreciate this perspective. Sometimes I try to be a bit like, how do you say that? So in a way, it's nothing different than just being attuned to whatever is happening with the patient. And if this situation is a psychedelic experience, then you're compassionate with that experience. So like you could say it's nothing different in terms of the attitude and the embodiment of the therapeutic qualities. But of course, I agree that it needs some training, but it's like 2 different perspectives. Ours is 3 years and very experiential. And sometimes I'm just surprised also how the regular psychotherapy training that some have as a background, how little this contains experiential work. So I think the more foundational training already contains experiential work, the more you might be familiar with with experimenting. And then, in a way, like we were talking about developing and cultivating therapeutic qualities that are necessary for whatever you do. In a sense, also, I think integration is a hype word, and of course we do integration, but psychotherapy is nothing more than integration of whatever you have experienced so far. And if this happens to be a psychedelic experience, then you're dealing with that as well. But like these ideas of course, we knew and we use that vocabulary, and I think it's super important to have training in that field. but in a way we also invent new concepts for things we should anyway be cultivating in a way.
I think there is, of course, a difference between what you would do to someone suffering from psychosis and someone who is in a psychedelic state. That is, to someone in psychosis, you would say, let us help you to get rid of this situation. Whereas in someone in a psychedelic state, you would say, can you go there and see what's happening to you? So that is obviously a very different attitude, and that is also a change that I also saw in our team, also therapists, how you need to differently relate to that type of state. So instead of making it go away, you say, embrace it, be there with it. But obviously the difference is that you know that it will be over in a few hours, which is not the case with psychosis.
I've worked in psychiatry, which is on festivals, and one of the first things that surprised me was like I was there thinking, oh, I'm going to be here for the people that have difficult psychedelic experiences, and then a very experienced psychiatry facilitator said, actually, the most challenging ones are the people that didn't take their medication on the festival and didn't sleep, and then there's sound continuously. And indeed, I worked with someone that was much more in a sort of pre-psychotic state, and was not on any substances. But to your point, I do think that there's a significant difference between kind of like framing even these states as pathological or as actually incredibly fruitful and fruitful ways of deepening a therapeutic process beyond what it might do in the brain or on the hardware. I don't like that distinction, but so I do think that there's significant differences in how we work with these states. And I'm curious, what is it that you do in 3 years, we do in 2 years that we think needs to be taught? Like, and I'm curious also for you, because you're a PI in a study.
Yeah.
Like what do you want from your therapist?
Well, I think that the most important thing, which was luckily present in people that I've worked with so far, is the ability to connect and to be compassionate about patients. And I knew I wanted to work with the people who were in my team because I knew that this was the way how they worked as mental health care professionals outside psychedelics. So I knew that these were people that you can trust together with a very vulnerable patient. So also with a very vulnerable patient in a very different state. And so the ability to connect, to be trustworthy, to be present, those I think are the core skills that you will need to actually work with patients in psychedelic therapy. I think that can be taught, but I also think that this is something that is in you. And luckily, many people who want to work in mental health care do have this in them, because otherwise they would not want to be connected all day with people that are suffering from all sorts of difficult emotions. But I think that is the core skill set that will need to be present. And that I think in the training program you would also be. I think you should look for that, and I think it would be good to also discuss with people who lack that skill if this is actually something that they want to do.
Thank you. I would like to open for questions. It's so interesting. I had so many questions. I went to all the questions before, so I kept listening, but I would like to open with anyone in the room would like to ask any questions. We have some in the chat. If you like, please.
Oh, yes, I mean, so many. First of all, thank you so much for sharing your expertise with us here. It's so insightful. My name is Nina. I'm currently a student of the Masters at Exeter, Psychedelics, Mind, Culture, and Medicine. And apart from that, I've been an underground psilocybin facilitator for 7 years now. Of course, because I'm now in the week of treating metaphysics of the mind, this is really a lot. It's really in my environment, in my sphere. So I have a question around, and I really get both of the standpoints of not having to have the experience with psychedelic as a therapist. But one of the things that I always share with my participants, I do either group or private sessions, is please don't expect anything, right? It's like you can have a certain intention to go into this, but as any psychedelics, and my expertise is only with psilocybin, can be very, very different from why you might go into it. And especially in regards to what might come up from a spiritual point of view, people can go into like completely different metaphysical positions that they're used to. And then if you're as a therapist, not if you've never encountered any of these situations yourself in regards to a psychedelic experience, how will you then sort of how will you counter that, and how will you help integrate a client then if something that has come up is completely different from why somebody is there with you, and you're specifically trained for depression, for trauma, for anxiety, but all of a sudden here come all these existential, metaphysical questions, spiritual questions.
I wonder why existential questions could not also be part of like everyday life non-psychedelic therapy, because like I think this is something very human to like ask existential questions. So I think it's about being curious. What was it? What did you experience? How did you experience it? And what does it mean for you? I think what can become critical is when you have had psychedelic experiences and it had the quality of being the last truth, and you're too much into that, and like if you're becoming like a guru or too much like a spiritual guide, I think this is critical. But if you're open, I guess it's a very important thing. The more you have experience generally in life, the more you might be able to be open for what your patient is going through. But existential questions, or I don't think they are specific to psychedelic experiences.
No, of course not. No, of course not. But I think especially because we're talking about here in regards to a therapy and psychotherapy for specific diagnoses, right? So a client comes to the psychotherapist with a specific diagnosis, and then the outcome of the therapy or something that might come up be completely different from the intention why somebody is there. I'm just very curious as well how a psychotherapist would then go about that, you know?
Yeah, I would say most of the patients I work with daily have many diagnoses, so it's quite fuzzy. But I was thinking about the thing that you started your question with, that is the idea of not expecting too much. So the patients that I work with in psilocybin treatment participate in a trial, and you always want to make sure that they do not expect too much, because they may end up in the active placebo arm in this trial, because it was, as I said earlier, a high, medium, and a very low dose of psilocybin. And all of our patients said, no, I'm very much aware of that. No, I do not expect anything. But still, they are very much prepared to expect something, because you do the preparation sessions and you see all the instructions. And then they have the administration. And then the day after, especially in those who were in the low dose arm or who did not experience too much from even a high dose, because that also happens, they said, yeah, I told you that I didn't expect so much, but I really expect actually quite a lot. And that is, I expect to recover from my depression very quickly and have a very lucid experience, etc., etc., etc. So people will expect a lot, and especially I think if you are in a depressed condition or in another psychiatric condition. So I think especially for this type of patient, it is actually very, very, I don't want to say burdensome, but stressful, because this is something that may actually finally bring to them what they did not get from all their previous treatments, from medication, from psychotherapy. So it is a very loaded experience. And also the risk for them is pretty high, because if this also doesn't work, then what? Well, then there may still be electroconvulsive therapy, MAO inhibitors, now esketamine nasal spray, but that's more of what they already tried. So I think that for this type of patient, it may be very different than from facilitating it for people that do it for existential reasons or religious or different reasons. So Yeah, that may be different. And another thing that I experienced is that most of these people did not come up with very hard to understand concepts. The things that they experienced were very much related to their condition. And it may have been some abstract form, it may have been, well, visualizations, but it was very related to the conditions that they were actually doing the treatment for. And this is the language that we already share with them. So the therapist could relate to the things that they were talking about, because it was about their depression, it was about who they were. And so I did not hear, or I did not see that there was sort of a language barrier or something between the experience they had and how they could deal with that in the integration sessions. But again, this was only a limited number of people, so we will need to see this in much more people to see the variation in that. But this is what I've experienced so far.
And I think what really helps is being curious and interacting with patients who have had this kind of experience, because Joost, the director of Open, he performed interviews with the patients who received ketamine treatment, and I think that was really insightful for us. And I assume we learned more from that than we would learn from 1 or 2 ketamine sessions ourselves, because what Joost, his interviews, the results of his investigation showed us that patients can have really overwhelming experiences, and what the importance is of the preparation and the setting, and that the set in which they go into the setting and the possible negative or challenging experiences they have, that also they work through to the next session, so they're very nervous or anxious for the next session. Those kind of results were very helpful for us, so it helped us more guiding new patients than I think 1 or 2 experiential trainings would have. So I think interacting with patients and gaining experience in guiding them is very important.
Okay, we will move to the next question, just so
Thank you.
it's a little bit shorter. That's a question from Elena, she's online, and how would you suggest psychedelic psychotherapist guidelines and or training programs should approach the alliance between therapists and patients? Is that clear? So how should you approach, how would you suggest psychedelic psychotherapist guidelines on training programs, how you should approach the alliance between therapists and patients? Yes, is that clear?
Very straightforward.
So, like for guidelines, I think this is an interesting
When it comes
question.
to the therapeutic alliance, I think.
Yeah, I mean, every relationship between a therapist and a patient is different. You cannot standardize it.
But I think if I can interpret the question, that's what we learned, it's best for the outcome, right? So I think the question, I'm speaking for Elena, which is the person who asked, how do you can potentialize that connection, if you can? I don't know. You have more experience in the training, I suppose.
That's interesting. I mean, I just have a few thoughts on that. So, for example, sometimes we say, yeah, before you even start the psychedelic treatment, you have to make sure that there's trust between you and the patient. And I think, yeah, makes sense. You need to have trust. But very often, or it happens that through the psychedelic treatment, you realize, oh, I did not really there wasn't trust. And you realize that through the psychedelic session, when there are all these intensified interpersonal little things. And then what you can do is work that through also in the phase after. So I think, of course, you need some sort of feeling of safety or stability enough so that both can say, yeah, we feel ready to do that. But the ideal of having a trustful, I mean, this is exactly the issue why many patients come to therapy, because of their interpersonal dynamics and relational patterns. So we cannot expect them to have that fully resolved before even doing it. So it's, yeah, I don't know if you can. It's just a thought about that question. It doesn't really answer it, but
I guess there isn't guidelines for that specific. It's something that is very hard. It's the connection. I think it's maybe what you said, that's
the qualities that you have that you maybe connect with someone and you don't. So that it would be really hard to find guidelines for exactly that. We are training, self-experience is one element of the training. So there are other ones that, which goes with the somatic practices and learning about yourself and meditation and the theory lines for that. I think that's the difficulty, right? Engage in this in this relationship. So I think yeah, so on the one hand you cannot standardize it, but you cannot also, I mean, you can go through all the contraindication, indication, but in the end it's also about the gut feeling. It's the same with screenings for research. You can go through all the criteria. It is good, and the few times I did not trust my gut feeling, it caused chaos. So in the end, yeah, even if everything is fulfilled, you're on a way together and it will mess you up. And what I heard recently from someone, therapy is about offering a stable relationship to patients that are used through their behavior to destroy relationships. So your job is to be in that contact, even if they try so hard through their dynamics and patterns to destroy it. So this is the job of us, and it's impossible.
Yeah, that's a very good point. And I think that paying attention to these type of challenges, to the importance of building a good relationship, good therapeutic relationship, but also with challenges, and that should be part of the program.
Yeah.
I mean, you should be very much aware as training therapists about the importance and the difficulties and the things that you cannot train about that.
Can I ask something about this? So would you say there is a big difference when using psychedelics compared to normal therapy settings that we know? Is there asked for the therapist?
In terms of how you relate to your patients?
Yeah, exactly.
From my perspective, no, I didn't deal differently with or approach the participants in our psilocybin treatment as those patients. I didn't do anything different from the patient that I treat on my ward or that I treat on the outpatient clinic. I try to be the same. Now, I mean, obviously, I try to adjust to what's required, but I don't think I did anything different. The importance of my role is being present, making them feel that I'm a professional that can be trusted, making them feel that they're in the hands of a good team. But that's also what happens when you're admitted to my ward and you come for electroconvulsive therapy. So I think that your core position in that doesn't change, or shouldn't change, maybe.
The core not, but still I think it's something tricky in that situation, because of course also in non-psychedelic therapies you have very vulnerable situations and regressive states and everything, but it's intensified in the psychedelic, and there might be moments where you think, well, this feels special, or we share something special, and there I think the issue of boundaries becomes much more critical. I mean, just make sure you have a good supervision all the time, because it's so easy, not only psychedelic sessions, but this is special, and then you start justifying. So you come very close. Of course, you do that also with other patients, but it's a little bit intensified sometimes.
No, that's a very good point. I totally agree with that. During around the actual session, of course, you need to take the changes in someone and the changes in your relationship into account. I mean, the whole period surrounding it. I very much agree.
And I think with regards to the guidelines for psychedelic work specifically, it's important to have guidelines regarding touch and therapeutic touch and boundaries in touch, and informed consent about.
But I think overall in the treatment course, you offer the same in terms of being available, offering, and being critical about what you offer.
We have a question from Nina. She wants to ask. Still there? Please unmute yourself and ask your question. Maybe put a message and then I ask the next one. I have one more question, two more. From Mount, with regards to today's question, what difference would it take to frame psychedelics experience in a therapeutic setting not only primarily as a psychological state, but a spiritual mode, then it may not be so much to do with having trust in one's expertise in the therapeutic guidance, but with needing guidance with spiritual expertise. I would like to hear the panel's reflection on this. Was it clear? The first time I can read it again. Yeah. With regards to the question, what difference would it make to frame psychedelics experience in a therapeutic setting, not only primary as a psychological state, but as a spiritual mode? Does that make sense?
Yeah.
Then it would make not so much to do with having trust in one expertise in the therapeutic guidance, but with needing the guidance with the spiritual expertise. Is that clear?
Yeah. And I understand it now, and I also have an answer now. I understand this. I can imagine that if this is the case, this could work. But if you give it in a hospital, it is not in a spiritual mode. You are in a medical setting, so you will need to provide, also medical assistance if required, for example. And the other challenge I see is that not everyone may experience this as being spiritual. There may be a lot of variety in how people have the experience. And then if you frame it this way, that might also be challenging, because then suddenly this person finds him or herself in a very different, non-spiritual, maybe challenging condition.
Yes, and I think that the people come to you for symptom relief and not for spiritual growth. So the goal is to have less depressive symptoms, or
Could be connected, no?
could be.
Well, I'm not sure if that's what you were pointing to earlier,
exactly.
And I do think this is not dependent on whether or not you have experience as a therapist yourself, but I do think as a therapist, you need to develop some competencies to work with a client that comes for a psychotherapeutic reason, has a profound mystical experience, and asks you, so tell me about what I just experienced. And then of course you can be curious, and I know that therapists are really good at, agnosticism, not proselytizing. And also I do think something else is required of a psychedelic-assisted therapist, to become very adept at working with transpersonal, spiritual, existential, metaphysical material in a way that is less common or less likely to occur, maybe actually with psychosis. I do think that there's something there in regular therapy.
It's interesting, like there are some people that say spirituality has nothing to do in psychotherapy. But as I understand, psychology is about what people experience and how they behave. And if spirituality is part of what they experience and behave, then this can become part of the psychotherapy. And also sometimes I wonder, what do we mean with spirituality? So isn't it just about like the question who we really are? And isn't it that many people are on this journey of trying to figure out who they are? And of course we treat maybe symptoms, but in psychotherapy, I mean, sometimes we do these checklists to kind of assess how they are doing, and sometimes if they have goals, then it's about symptom relief, but often through therapy, these goals change, and it's really not so much about the symptom. I think this is maybe a very specific view on psychotherapy, which is not my experience. So we don't treat symptoms, we engage in the psychotherapy and figure out what it's all about. No matter, and then also, I mean, so many experiences are boring, just somatic, frustration, pain, and sometimes it's spirituality or mystical or whatsoever. And the most spiritual I've ever experienced with a patient was just sitting there, and he said, the more I do this therapy, the less I experience the difference between these states. So I don't know what spirituality is.
I think
Sorry, please.
no, I was just going to say, I think I agree with you that it shouldn't matter what comes up in psychotherapy. I think as a therapist, you should be very non-judgmental. You should be able to hear what the person in front of you is talking about. And I also don't think as a therapist you need to provide all the answers. So if you cannot explain what the meaning is of the
the spiritual experience. I mean, very often as a psychotherapist, you can also not explain the meaning of someone's memory. It's just creating hypothesis, thinking with someone together about what has happened, what it may mean to you, seeking collaboration in that. But I think the non-judgmentality in that is very, very important. So in that case, it shouldn't matter what type of experience someone has, whether it is spiritual or existential.
Yeah, but I think the value of this training programs in this aspect, because this is something that we can teach of like how to honor really that person's experience, and it's super important. And that's why if you just straight up, it's legal tomorrow, all the psychiatrists start treating people with psychedelics, that it's the shift, obviously it's hypothetical, but I'm just saying that it's something that will create a lot of problems, not honoring that person's experience. We go to exactly the medical, this is.
No, and I think that there is very little attention for spirituality in psychotherapy, so it would be very useful to make therapists more aware of those phenomena and give them a framework for how to be in discussion about this.
Yeah.
So yeah, I think that would be a very much of added value to our current framework of thinking.
I think what you also have to try and exercise and develop is not acting. I mean, it's long sessions up to 8 hours, with LSD up to 10, 12. And I think when you start this therapy, you tend to interact or intervene easily because you think you want to help, and I mean, we all want to help a therapist, but then
And you're curious also, right, with what's going on.
yeah, you're curious or you want to help, or it's so difficult to experience the patient in severe pain and you want to like take that pain away. So the urge to help is something tricky. So just being there and not acting, and of course in some situations it makes sense to intervene, to support, but it can likewise be valuable to be there without actively supporting. So training to be still and to have many hours of just sitting, I think that's.
This is actually something where again, this can be trained without psychedelics. I agree with you. I don't think there should be a should in the sort of like tagline sentence. But I have noticed, having had a significant amount of experiences myself, that the non-intervention approach and a therapist just being with me or a facilitator being with me and being present but not doing anything, to have an internal experience of how reassuring that can be, that someone is just there not doing anything. And I've also worked with very experienced psychotherapists that would have never had psychedelic experiences, that would come to the retreat center I used to work to kind of like see what it's like to work with people under influence. And the main thing that many of them shared was the desire to intervene, especially when there's pain or discomfort or panic. And those therapists that had a lot of experience were much more comfortable just being with someone that was just straight up screaming, and just being with them and not trying to shush them or not trying to get an understanding of what's happening or not trying to control the experience, but just, all right, yeah, that's happening. And for myself, I do notice that I have much more trust in those types of experiences because I've been in some pretty weird places myself where I'm like, oh yeah, okay, yeah. And again, I know that might not be the same as what a client might be going through, but it did foster some sense of trust in even very difficult experiences like this. There's ways that this can be resolved without me having to do a lot of work as a.
Yeah.
But I'm curious how that is for you.
No, I think this is the what I referred to earlier. The big difference between how you are normally trained in mental health care is to make these type of challenges go away by prescribing medication or by prescribing or giving benzodiazepines. Whereas in psychedelic therapy, you will be there and ask the person to look into it a bit more further. And not doing anything. So I think this is where psychedelic therapy is very much at odds with what we are used to, how we are used to work in mental health care. That's the very new thing that many new therapists that are new to the field will need to feel comfortable with, to actually be there without intervening.
And I think you can also learn it by observing this process
Oh, yeah,
several
yeah,
times.
yeah.
But you might feel more confident just watching and not intervening when you've experienced it yourself.
And sometimes, I mean, it can also be valuable to go there and offer some help. So I think it's always
Right.
also like, also maybe be comfortable or not having not fearing that I will do something wrong, because yeah, in the end, it's about figuring out the relational process also, and from something that I thought was wrong, something very valuable can turn out in the process. But like the tendency to intervene, I think, is something that you experience in the beginning mostly. Maybe, and also like I mean, that's nothing specific to psychedelics, but paying attention to your own somatic resonance.
Mhm.
And sometimes, for example, you might be very confused or yourself get bored, and like to become aware of that and like also use it as a sensor, you know. And these things can be trained, but without that.
We are running out of time.
Oh.
Maybe we ask one more question from Mina.
Okay, Mina, if you're here.
Yeah, I'm here. So sorry about can you hear me well?
Your question.
Yeah.
Yeah, sorry. Yeah, I misheard first time. So this is about basically accessibility. But I live in the Middle East, so drug law, like especially in a place where the drug laws are very strict. So almost everything is inaccessible. At the same time, if you are accessible, it's like there is a lot of repercussions. So if a training is requiring that the therapist should have a psychedelic experience for themselves before they can treat patients for like something like Spravato or anything like this, wouldn't that exclude basically a whole region or a whole country from the therapist, because they cannot access the substance for their own experience? Therefore, if there is like Spravato is legalized, but they cannot access it for themselves, so wouldn't that exclude all the therapists in that to give such therapy?
Response, which is that I would personally say that the main issue here are the drug policies in that given country, and those need to change. That being said, within that context, yeah, this is a real risk, and it's a legal issue that we need to address.
Yeah, so my question is like,
Yeah, I mean, this is one of the issues in most countries,
Yeah.
right? That we don't have access to that type of personal experience in comparable settings. I mean, there are, I think, three access pathways. One is medicalization, one is through spiritual religious use, which, for example, in Switzerland by law is not an option, or in studies, or legalization. So there are pathways, and depending on the legal situation, some of them are accessible, and medicalization, if you don't have an indication that allows you to get that, then you can't have it.
I fully agree with you. I would add that there is always a fourth pathway, which is in the underground. And I think one of the things that is so difficult for policymakers to understand is that the fact that you prohibit something doesn't make it go away. It just prevents real harm reduction strategies reaching the clients that need those strategies. And so, yeah, I don't want to get trapped in a conversation about drug policies, but it just it's very relevant to understand that this talking about psychedelic assisted therapy should not be divorced from having deep conversations about the fact that drug prohibition doesn't work, is ridiculous, and it's actually harmful. So,
But I think it can also be harmful suggesting this pathway of the underground way of experiencing psychedelic, because if it can have serious repercussions, it's quite dangerous to suggest it, right?
Oh, but I'm don't get me wrong. I agree with you. It's not so much that I'm suggesting it. It's much more that I used to work in a smart shop, in the Warmstad. I'm not sure if you're from Amsterdam. This is a very busy street. There's a lot of tourists coming in. Every now and then, a very drunk British tourist would say, "I want truffles." It's difficult to really understand what they're saying, and I would choose not to sell it to them, knowing fully well they can go down any of the other smart shops and buy it there, and many of them will. But I have a sort of like, okay, but I'm not going to be the person selling it to you. But what I would always say is like, please consider me recommending not selling it to you, something that I recommend. It's like a strong recommendation. But I had no illusion that for the majority of those drunk British people, that would prevent it. So I'm not encouraging people to go underground. I just think the expectation that making it illegal will prevent people that are desperate, that, you know, and that hear such beautiful things about psychedelics, that they will look for help and unfortunately probably go to, unsafe settings.
Yeah, it's very important to be aware of the
Yes, yeah.
Thank you so much. We're running out of time. I don't want to hold people from the online, so thank you all very much for being here. It was a great discussion. Really enjoyed it. I think we could have another 2 hours. Go for dinner, right?
Yeah, we go for dinner. Yeah.
Thank you so much. So yeah, I just want to say thank you very much for those who are following online. You guys sharing a slide with the QR code from our professional community and ADAPT program, so you can find more information on our page. And if you have any other questions, please email us. Myself and Dan will be here, happy to answer your questions about ADAPT. We also have a Q&A on the 28th of January. It's at 8 p.m. It's online. So we hope to hear from you. And thank you so much. Thank you, Patricia, Yulia, and Jasmine for organizing this panel. We really appreciate it. Thank you.